pleasure today to have Dr. Baliga join us. He is our senior faculty member in Pediatric Nephrology. Dr. Baliga was actually there when the kidney was invented. He knows a lot about the kidney.
Suddenly makes me feel old, though.
No, he invented it. So, acute kidney injury, very common in kids, and even more common on your board exams and step exams. So, always something to pay attention to. Even in my humble field of infectious diseases, we induce some kidney injury that Dr. Baliga has to help us recover from. So, complicated topic, but Dr. Baliga is
It's a common topic.
the master.
Thanks for the intro. and good morning to you all. I have nothing to disclose. Acute kidney injury has largely replaced acute renal failure since it clearly defines the extent of kidney injury that can occur. It is a relatively common syndrome with a high morbidity and mortality rate. And even though majority recover and do well, there are those that develop compromised kidney function and proceed to develop end-stage renal disease. Hence, it's extremely important to have a working knowledge of the common causes and an approach to the management of this condition. What I'm going to do today is define acute kidney injury, outline the various causes, and the approach to diagnosis, management, and prevention. And if time permits, I'll present a case that I was consulted on at Ochsner with student and resident participation. Now, acute kidney injury may be defined as a syndrome in which there is abrupt decline in the ability of the kidneys to maintain homeostasis of the body fluids and is represented by a rise in serum creatinine and or a decrease in urine output. Now, the rise in serum creatinine is always delayed after the onset of kidney injury by at least 24 to 36 hours. Hence, it is an imprecise test as it only represents GFR in a steady state in someone who has a stable kidney function. However, it does not accurately estimate the GFR in a child who is critically ill and has changing kidney function. Hence, to better define acute kidney injury, the rifle classification was introduced based on the changes in the serum creatinine and the urine output. It consists of 3 graded levels of injury, namely risk, injury, and failure, and 2 outcome measures such as loss and end-stage renal disease. The pediatric rifle classification is a modification of the adult classification and is also based on the estimated creatinine clearance and the urine output. Risk is where the estimated creatinine clearance is less by 25% and the urine output is less than 0.5 ml per kg per hour for 8 hours. Injury is where the estimated creatinine clearance decreases by 50% and the urine output is less than 0.5 ml per kg per hour for 16 hours. Failure is where the estimated creatinine clearance is decreased by 75% or the estimated creatinine clearance is less than 35 ml per minute per 1.73 meters square, or the urine output is less than 3 ml per kg per hour for 24 hours, or anuria more than 12 hours. Loss is where the kidney failure persists for more than 4 weeks, and end-stage renal disease is where the failure persists for more than 3 months. Now, in a euvolemic child with stable kidney function, the normal urine output is anywhere from 1.5 to 3 ml per kg per hour. Oliguria is where the urine output is less than 1 ml per kg per hour in infants, or less than 0.5 ml per kg per hour in children for more than 6 hours. Non-oliguric acute kidney injury is seen in neonates because they lack the concentrating ability. Polyuric acute kidney injury is seen during the diuretic phase of ATN, and of course anuria is no urine output. The etiology of acute kidney injury varies globally. In developing countries, volume depletion such as gastroenteritis, infection as in sepsis, and primary renal disease such as hemolytic uremic syndrome and post-infectious nephritis are the most common causes. However, in developing countries, during the past 2 decades, the trend has changed from volume depletion and primary renal disease to hospital-acquired causes such as sepsis, nephrotoxins, congenital heart disease, and renal ischemia, especially in kids that are chronically ill. The incidence of acute kidney injury has been increasing over the past few years because of the improved technology in treating AKI and kids with chronic illnesses. 30% of preterm and 50% of neonates with asphyxia had a serum creatinine greater than 1.5 milligrams per dl. The incidence of acute kidney injury was 30 to 40% in kids with congenital heart disease who underwent cardiac surgery. The incidence of acute kidney injury in kids with bone marrow transplant ranges anywhere from 15 to 34%. 6% of children that are admitted have AKI, and 10% develop AKI during their stay in the PICU. The incidence of AKI increases to almost 80% in children that are on mechanical ventilation. Now, the classification of acute kidney injury can be broadly divided into prerenal disease, which is an oliguric state where there is diminished blood flow or perfusion to the kidneys, and is rapidly reversible if the cause of the hypoperfusion is corrected. The intrinsic kidney disease is where there is actual structural kidney damage, and postrenal is where there is obstruction distal to the kidneys, which could be either congenital or acquired. It can be less frequently classified into community acquired, where there is a predominant insult such as gastroenteritis resulting in volume depletion and is frequently reversible with good prognosis. Or it can be hospital acquired, which is multifactorial, normally seen in a hospital setting in PICU, and results in short or long-term consequences. Now, prerenal acute kidney injury is one of the most common causes of acute kidney injury, and can be broadly divided into decreased effective circulatory volume or diminished cardiac output. The decreased effective circulatory volume could be secondary to hypovolemia or maldistribution of blood. Hypovolemia mainly results from gastrointestinal losses such as gastroenteritis, hemorrhage, renal losses, namely polyuria secondary to diabetes insipidus or diabetes mellitus, and cutaneous losses as in cystic fibrosis. Maldistribution of blood, namely third spacing, could be secondary to nephrotic syndrome, burns, septic shock, and vasodilatation. Diminished cardiac output can be secondary to cardiomyopathy, pericardial effusion, arrhythmias. The intrinsic causes of acute kidney injury can be broadly classified into glomerular diseases, renovascular lesions, tubular lesions, and interstitial involvement. Among the glomerular diseases, the most common are acute post-infectious nephritis, rapidly progressive nephritis, HSP, and lupus. Among the vascular lesions, one needs to consider hemolytic uremic syndrome, polyarthritis nodosa, and Kawasaki's, including Wagner's. ATN, or acute tubular necrosis, is one of the most common causes of intrinsic acute kidney injury and could be secondary to ischemia reperfusion injury. Nephrotoxins, namely drugs, antibiotics such as aminoglycosides, chemotherapeutic agents such as cisplatin, radiocontrast agents, toxins, heavy metals such as gold and mercury, and ethylene glycol, which at one time was one of the common causes of AKI, where children would drink it as Kool-Aid, and pigment associated such as hemoglobinuria and myoglobinuria. It could be secondary to interstitial lesions, especially drug-induced, namely penicillin, infections such as pyelonephritis, infiltrative lesions as in malignancy, and of course idiopathic interstitial nephritis, or sometimes we call it the pie syndrome. Postrenal acute kidney injury is rare compared to prerenal and intrinsic renal, and could be either intrinsic or extrinsic, and is seen in about 2 to 15% of cases of acute kidney injury. The obstruction could be at the level of the collecting duct, renal pelvis, ureter, bladder, or urethra. And the most common is stones at these various levels or fibrous bands. And of course, at the level of the urethra, the posterior urethral valves that can result in bilateral hydronephrosis. Functional abnormalities, namely neurogenic bladder, is seen in cases like spina bifida. Certain sympathomimetic drugs can cause bladder dysfunction. The diagnosis of acute kidney injury can be made from the classic signs and symptoms, namely edema, decreased urine output, gross or microscopic hematuria, and elevation in blood pressure, accompanied by laboratory findings such as a rise in serum creatinine and abnormal urine analysis. Since the rise in serum creatinine is often delayed and it's an imprecise test of kidney function, researchers have come up with specific biomarkers of kidney injury such as NGAL, KIM1, and IL-18 that are upregulated with the onset of the kidney injury and allow early intervention even before the rise of the serum creatinine, presence of volume overload, or any electrolyte abnormalities. The evaluation of a child with AKI should include a thorough history and a meticulous physical exam, including followed by laboratory evaluation and imaging studies. In the history, one should inquire into fluid loss, such as diarrhea and vomiting, diuretic abuse, exposure to nephrotoxic agents, namely aminoglycosides, contrast agents, and factors associated with glomerular disease, such as history of sore throat, skin rash, or joint involvement. One should also inquire into urinary stream. Fluctuating urine volumes may indicate intermittent obstruction. On physical, one should inquire into intravascular volume, signs of intravascular volume depletion, such as dry mucous membrane, a low blood pressure, signs of volume overload, which includes heart failure, hypertension, pulmonary edema, and signs of renal disease, again, joint swelling, skin rash. If there is bilateral palpable flank masses, you need to think in terms of polycystic kidney disease. If there is a unilateral flank mass with hematuria, you need to think in terms of renal vein thrombosis. If there is a palpable suprapubic swelling, you need to think in terms of obstruction. Anuria is rare, and if you have anuria, you need to think in terms of bilateral ureteral obstruction, or you need to think in terms of rapidly progressive nephritis, or diffuse cortical necrosis, or bilateral renal arterial occlusion. Now, the pH of the urine is anywhere from 5 to 7.5. If you have an acidic pH, you need to think in terms of prerenal azotemia or glomerular disease. If there's presence of blood, it either indicates intrinsic kidney injury or obstruction and is related to the heme pigments. Absence of RBCs should make you think in terms of either myoglobinuria or hemoglobinuria. The proteinuria is 1 to 2 plus in cases of ATN and interstitial nephritis, but is more than 2 plus in cases of glomerular involvement. Now, microscopic examination of the urine sediment is extremely important in the differential diagnosis. Presence of RBC CAS should make you think of nephritis. In cases of ATN, you will find the characteristic fine and coarse granular CAS, including the renal tubular epithelial cell CAS. The presence of eosinophils in the urine should make you suspect interstitial nephritis, which is allergic in nature. Now, the chemical composition of the urine is extremely useful in differentiating between prerenal azotemia and intrinsic acute kidney injury. In prerenal azotemia, the tubules are intact, so the urine osmolality will be higher than the serum osmolality. The urinary sodium will be less than 20 because there is increased reabsorption of salt and water because of the hypoperfusion. And the fractional excretion of sodium will be less than 1%. And the prognosis is good. In cases of intrinsic acute kidney injury, the tubular integrity is lost. So the urine osmolality will be equal to or less than the serum osmolality. The urinary sodium will be more than 40, and the fractional excretion of sodium will be more than 2, and the prognosis is guarded. This basically shows that the fractional excretion of sodium is one of the very sensitive tests, because you see that there's hardly much of overlap between ATN and prerenal azotemia, whereas there's considerable overlap with urine osmolality between these two conditions, including with urinary sodium. Now, additional tests should include a CBC to rule out any consumptive coagulopathy, metabolic panel to rule out any chemical abnormalities, complement studies, and streptococcal serological tests to rule out post-infectious or post-streptococcal nephritis, and ANA to rule out lupus. Aminoglycoside level in cases if you are suspecting nephrotoxicity from drugs, and uric acid in cases of tumor lysis syndrome. Now, by means of a plain film of abdomen, an ultrasound, and a renal scan, you might be able to come to a relative diagnosis as to the cause of AKI. An IVP is pretty much outdated unless it is for medullary sponge kidney. The plain film of abdomen should help to identify 90% of radio-opaque stones. The ultrasound will give you an idea about the size and shape of the kidney and if there is any obstruction, and also if you do Doppler studies, the blood flow to each of the kidneys. A renal scan will give you an idea about individual function of the kidney. A renal biopsy is rarely performed with ATN unless the oliguria or anuria is more than 3 weeks, where there is evidence to suggest systemic involvement and there is known exposure to drugs that might be causing interstitial nephritis. Now, chronic disease can be differentiated from acute kidney injury because there will be a previous history of kidney problems such as frequency of urination, frequent UTIs, polyuria, polydipsia. If there's a strong family history of kidney disease, such as polycystic kidney disease or Alport's, if there's impaired growth, which could be secondary to chronic metabolic acidosis, evidence suggestive of renal osteodystrophy, which can result in short stature, and an ultrasound that might show bilateral small scarred kidneys. Now, since majority of the causes of acute kidney injury are prerenal in origin, the first and foremost thing that one needs to do in the presence of hypervolemia is to give a fluid challenge. And this can be done with 10 to 20 ml per kilogram of an isotonic solution or 5% albumin given over 30 minutes. It can be repeated until the intravascular volume is full. Once the intravascular volume is full, if the child is euvolemic, then the fluid management should basically consist of insensible losses plus the urine output. The insensible losses can be given as 300 to 500 ml per meter square per day of an electrolyte-free solution, while the urine output needs to be replaced accordingly. In presence of hypervolemia, where there is hypertension, evidence suggestive of pulmonary edema or congestive heart failure, you can give a single dose of furosemide at 2 to 5 ml per kilo to see if you can convert the oliguric acute renal kidney injury to a non-oliguric variety, which has a better prognosis to an extent. If that is not successful, then you may have to resort to dialysis. This basically shows the insensible losses in the various age groups. If less than 6 months is 40 ml per kilogram per day. If it is the kid is between 6 months to 5 years is 30, 5 to 10 years is 20, and in adolescence is 10 ml per kg per day. Acute kidney injury results in a severe catabolic state, hence an aggressive nutritional support is necessary. In infants, one needs to provide at least 120 calories per kilogram per day, and if it is a child, it should be at least 125 to 150% of the maintenance needs. It also results in protein catabolism with muscle breakdown, so one needs to at least provide, and there's negative nitrogen balance, so one needs to at least provide 2 to 3 grams per kilogram per day of protein. Majority of the centers may even resort to hyperalimentation because these kids are not able to tolerate enteral needs because they may have nausea, vomiting, anorexia. Electrolyte abnormalities are common with acute kidney injury, and if the child has oligoanuria, one should avoid supplementation of potassium or phosphorus. The sodium should be restricted to at least just 2 to 3 milliequivalents per kilogram per day to prevent salt and water retention. If the child has polyuric acute kidney injury, then you need to replace the electrolyte losses accordingly. The greatest danger of hyperkalemia is its effect on the heart that can produce fatal arrhythmias. The hyperkalemia could be secondary to reduced GFR, decreased tubular secretion of potassium, tissue breakdown, and metabolic acidosis. The symptoms are basically non-specific, such as malaise, nausea, and muscle weakness. The EKG changes basically consist of peaking of the T waves, prolonged PR interval, flattening of P waves, widening of the QRS complex, and ventricular fibrillation. This basically shows the different changes that occur: peaking of the T waves, flattening of P wave, widening of the QRS complex, and then of course you have the sine qua non phenomena. If the serum potassium is less than 6.5, then you need to eliminate the potassium intake, and you can give, and there are no EKG changes, you can give K-oxalate at 1 gram per kilo to reduce the serum potassium. However, if the serum potassium is greater than 6.5 and there are EKG changes, then it constitutes a medical emergency. And you need to start with calcium to stabilize the myocardium, followed by sodium bicarbonate that will drive the potassium into the cells. You can also resort to glucose and insulin. It's 1 unit of insulin for every 5 grams of glucose. And you can also give the albuterol, which reduces the potassium by 0.5 to 1 milliequivalent in about 30 minutes. However, all these measures are only temporary and should be followed by K-oxalate at 1 gram per kilo, which can be given every 3 to 4 hours. However, K-oxalate exchanges 1 milliequivalent of potassium for every 2 milliequivalents of sodium. So you need to watch for sodium overload. Metabolic acidosis invariably occurs in acute kidney injury and is mainly due to the retention of the sulfates, the phosphates, and the hydrogen ions, resulting in an elevation in the anion gap. The total amount of bicarbonate to be given can be calculated from the deficit, which is 24 minus whatever the bicarbonate is, times 0.5, which is the factor of distribution, times the weight in kilos. You can give half the deficit in about 2 to 4 hours, and the remaining half can be given over 24 hours. You need to be cautious about giving bicarbonate supplements, and should be reserved only for severe acidosis or hyperkalemia. I normally tend not to correct the acidosis unless the pH is less than 7.25 or the CO2 is less than 15. A word of caution is that it can also cause decrease in the ionized calcium and can precipitate tetany. Hypocalcemia invariably occurs with acute kidney injury and is mainly due to the hyperphosphatemia and decreased conversion of the vitamin D to the active form in the kidney. The key to correction of hypercalcemia is to lower the serum phosphate and not to give any calcium supplements, because if the calcium phosphorus product is greater than 60, it can result in soft tissue calcification. And you can do that by restricting the amount of dietary phosphate and give phosphate binders. Once the serum phosphate is down to normal, then you can give calcium supplements and vitamin D to increase the calcium absorption from the gut. Hypertension is seen with acute kidney injury and is mainly due to the fluid overload and can be managed under most circumstances by limiting the amount of fluid intake, by providing diuretics and oral antihypertensive agents. However, if the hypertension is severe, one may have to resort to antihypertensive agents such as nicardipine, which is a calcium channel blocker, labetalol, which can be given as mini boluses or as a continuous IV infusion, which is an alpha and a beta blocker, and sodium nitroprusside, which is a powerful vasodilator, but the word of caution is the fact that it can cause accumulation of thiocyanates in the presence of acute kidney injury. And hence you should need to monitor the thiocyanate level. So it's mainly reserved for those kids that are on dialysis. Convulsions in cases of acute kidney injury are multifactorial and are due to CNS alterations either from uremia or hypertension. It could be also related to metabolic abnormalities such as hypoglycemia, hypocalcemia, and hyponatremia, and should be treated accordingly. Infection is one of the dreaded causes because it can increase the mortality. The reason is that you can have a resistant bacteria and lack of the excretion of the bactericidal medication. The source is the GU tract, and the two most common bacteria you need to think of are Staph aureus and gram-negative rods. This basically shows that the frequency of infection is increased with routine ureteral catheterization and also by routine prophylactic antibiotics. Hence, one needs to avoid prophylactic antibiotics and routine bladder catheterization unless necessary. You need to provide strict surveillance of intravenous lines, and majority of the centers perform early dialysis to improve the well-being of the patient and to improve also the resistance of the infection. Nephrotoxic drugs should be administered with caution in the presence of acute kidney injury. If the GFR is less than 50, one needs to reduce the dose or reduce the frequency of administration. The drug levels need to be monitored very closely to maintain in the therapeutic range and to prevent any nephrotoxicity. However, if the child is on CRRT or continuous renal replacement therapy, then the dose adjustments need to be made more frequently because of the increased clearances. About 15 to 20% of kids with acute kidney injury will require dialysis. Renal replacement therapy should be provided if there is severe fluid overload resulting in hypertension, congestive heart failure, or pulmonary edema that is unresponsive to diuretics. If there is hyperkalemia and severe metabolic acidosis that is unresponsive to conservative management, if there are uremic symptoms such as lethargy, or if there are signs like pericardial rub, and majority of the centers perform preemptive renal replacement therapy to prevent complications rather than to treat them. So majority of the centers just do preemptive dialysis. Now, since the 1990s, there has been a surge in the different dialysis modalities, namely continuous renal replacement therapy, and also you have what we call SLED, which is sustained low efficiency dialysis. And of course, we have the hemodialysis and the peritoneal dialysis. The CRRT and the SLED has been adopted to children. The choice of renal replacement therapy will depend upon the age and the size of the patient, the kind of acute kidney injury, and of course institutional resources and support. Hemodialysis is specially suited for older kids who are able to tolerate extracorporeal volume and rapid changes in fluid and electrolytes, including acid-base. It requires a central venous access and specialized equipment, including trained personnel. Peritoneal dialysis is the preferred modality in developing countries because it is economical, it is technically feasible, and easy to perform. It is specially suited for neonates and small infants because there is gradual removal of fluid and slow correction of the metabolic imbalance. CRRT, or continuous renal replacement therapy, is specially suited for those kids in PICU who have multi-organ failure, are hemodynamically unstable, and require slow removal of fluid without significant shifts. Now, acute kidney injury can result in increased mortality and long-term morbidity. The mortality rate, as you see in the studies, is anywhere between 27 to 29%. It is greater in kids that are in PICU who have multi-organ failure and are on renal replacement therapy. The survivors of pediatric acute kidney injury are at a risk for long-term complications. As you see in the studies, in this retrospective study of 177 children with acute kidney injury, almost 34% had reduced kidney function or were dialysis dependent. And in a similar study of 126 children with acute kidney injury, 10% had CKD and 47% were at a risk for developing CKD. So it's extremely important to follow these kids who survive acute kidney injury. Mortality is increased in the presence of sepsis, the development of AKI in kids that would have undergone cardiac surgery, where there is multi-organ failure, and lastly, you see this in developing countries, delayed referral. Now, prevention is the ultimate therapy, and this can be done by early recognition of prerenal conditions and aggressive management. One needs to provide hydration prior to administration of radiocontrast material or any nephrotoxic antibiotics. Provide inotropic support if there is hypotension when volume repletion is adequate. Administer nephrotoxic drugs cautiously and provide hydration in the presence of hyperuricemia and pigmenturia to maintain the urine flow. Now, this is a case that I was consulted on. It's a 8-year-old white female involved in a motor vehicle accident, was transferred to the PICU for increasing abdominal pain, non-bilious emesis, and persistent tachycardia. On exam, her temperature was 101.9, heart rate of 160, blood pressure of 124/55. Abdomen was diffusely tender with hypoactive bowel sounds. She was taken to the OR for X-lap, became hemodynamically unstable, and arrested in the PICU. Her urine output had significantly decreased, and her kidney function was compromised. During her stay in the PICU, she required antihypertensive therapy, including anticonvulsants. A urine culture grew Pseudomonas and Klebsiella from the hemodialysis catheter. CBC showed a white blood cell count of 3,900, hemoglobin of 10, platelet of 50,000. Urine was amber colored with 2+ protein, large for blood, and there were only 25 RBCs per high-power field. Serum lights indicated a serum sodium of 134, potassium was 7, CO2 of 10, chloride of 102. The serum calcium was 6.5, phosphorus of 6.7, albumin was 1.5, liver enzymes were markedly elevated. The EKG, by the way, showed changes consistent with hyperkalemia. On X-ray chest, there was cardiomegaly with perihilar edema. The kidneys were of normal size, and the echo showed severely depressed cardiac function. Now the questions to be answered, and this requires your participation. What do you think of the CBC and the urine analysis? If there's nobody who answers, I'm going to ask Alexis because she's rotating with me.
Okay, so her white count.
I mean, if nobody wants to volunteer, then I'll be picking on you.
Yeah, so it was
The white count is,
cell lines are low.
huh?
All the cell lines are low.
Especially platelet count. What about the urine? It's large for blood, and there are only 25 RBCs. So there's DIC, or consumptive coagulopathy. Electrolytes. What do you think about these electrolytes? Huh? There's severe acidosis. What else? What about what else do you look for? Anion gap is increased. Now, how would you like to address the acidosis, the hyperkalemia, hypocalcemia? You know that she has EKG changes. So you'll give calcium gluconate. What else? You need to speak loud. I can't hear.
Well, since she's acidotic, we don't have a pH on her, but you could treat her acidosis with the bicarb, or you could do the insulin glucose to get her potassium down.
If you're going to give bicarb, what will you be concerned about? I had mentioned it in my talk earlier. So you might if the ionized calcium is low and you are giving bicarb, you might precipitate tetany. So you need to make sure that you at least bring the calcium up. And then of course correct bicarb only to an extent, not to correct the bicarb, but to drive the potassium into the cells. You see?
Are you asking?
Yeah, I'm asking.
Should she get dialysis?
What
What dialysis?
What dialysis? I mean, I know it says he has to go to dialysis. Huh?
She's trying to get CRT.
Yeah, CRRT, because she's hemodynamically unstable. There's fluid overload, and you won't be able to get all the potassium. You see, so she has to be on CRRT. Yeah, because she'll be losing on CRRT. Of course, that's one thing I didn't mention, was that with any dialysis modality, you lose more protein. Nutrition. Aggressive nutritional management. Because what? Hyperal. She should be on hyperalimentation. Of course, seizures depends upon what it is. You need to seizures and, of course, infection. You are giving antibiotics and also, but that depends upon whether it's metabolized by the liver or excreted by the kidney. And also antibiotics. So it is CRRT, depending upon what it is, you may have to give antibiotics more often. Hypertension. What will you like to give? Of course, you have on CRRT, the blood pressures may improve because there's volume overload, but still the kid would require antihypertensive. What would you like to give? I mean, it shouldn't take that long. Yeah, you have to put her on a drip. So you'll give either Lobettol or Nicardipine, either one of the two. She survived. She guarded. Okay, good. So, acute kidney injury is a relatively common syndrome with uncertain pathophysiology, requiring expensive treatment and carries a guarded prognosis. That's the message. Thank you all.
Dr. Baliga, can you put your slide back with the labs and stuff? Since my brain is still in test-taking mode, my question to you is, which one of those things do you need to treat first? Which thing do you need to do first?
Hyperkalemia. Oh, you're asking me or you're asking them? Oh, I thought you were asking me.
So how are you going to treat the hyperkalemia first with the kid on the floor with only a peripheral IV?
Well, first thing with calcium gluconate is the EKGs changes.
So the first thing you need to do is stabilize the myocardium by giving calcium gluconate, and you can do that through an IV. And then you get them to the unit and start working on all the other stuff. But most people think hyperkalemia, oh, let's start getting rid of some of the potassium. The first thing you have to do is stabilize the myocardium by giving the calcium gluconate. So that's the first thing you need to do in this kid, and that's typically what the test question is going to ask. They'll give you this scenario and ask you what is the next best step, or what is the first thing you need to do.
And the first thing you need to do is eliminate all sources of potassium.
Right.
Before you can even give anything
So
else.
while the nurse is going to get the calcium gluconate, make sure nothing else is giving you any.
Okay. Any other questions? 2 seconds.
Yeah.
All right, very good. Thank you, Dr. Baliga.
Thank you all.